Okay, thank you for joining today's Ohio ACEP informational Zoom on ABEM Certifying Exam. My name is Holly Dorr, and I am the Executive Director of Ohio ACEP. Before we introduce our speaker today, I'd like to extend a big thank you to our resident board member, Dr. Mary Feliu, for organizing today's session. I'd also like to introduce Dr. Bob Jones, Chair of our Candidate Young Physician Committee. And I will go ahead and hand the virtual stage off to Dr. Jones to say a few words.
Okay. I just want to thank Dr. Gorgas, and I want to thank first, Ohio ACEP for hosting this. I know there's a lot of questions surrounding this new certification examination, and we're excited that we have the ABEM President, Dr. Gorgas, here to help kind of answer some of these big questions. And I know many of you are going to be watching this on the recorded end of things, and we are going to try to answer as many questions as possible and give you the overview of what is to come. So with that, we can.
Hello, everyone. Thanks for being here. I am very excited to have Dr. Diane Gorgas, who will be discussing changes to the EM licensing exam. So a little bit about Dr. Diane Gorgas. She is the president of the American Board of Emergency Medicine Board of Directors. Dr. Gorgas is a professor and vice chair of academic affairs in the Department of Emergency Medicine and the executive director of the Office of Global Health at The Ohio State University in Columbus, Ohio. She received her medical degree from Case Western Reserve University School of Medicine, and she's been in practice for more than 30 years, 9 of which were as a residency director. She practices clinically at the Ohio State Wexner Medical Center. Dr. Gorgas specializes in lifelong learning and self-assessments. She is dedicated to examining ABEM's present and future assessment to help maintain a high standard for all emergency physicians impacting our specialty and our patients. To ensure efficiency of our meeting, we're going to ask everybody to please hold your questions until the very end. And whenever that time, when we open the floor for questions, please press that hand button and I will call on you to appropriately, promptly ask your questions. And now, without further ado, Dr. Gorgas.
Thank you so much. And thank you to Ohio ACEP for having me here today. We are really excited to get this information out there. So without further ado, I'm going to share my screen. Okay, and I'm hoping that you're seeing ABEM Certifying Exam. Perfect. Okay, as I said, thank you so much for allowing me to join you today. I'm really excited. As you've heard, I'm an Ohioan, and I was born and raised here, so I have a special place in my heart for making sure that Ohio residents do particularly well in the certifying exam. And again, thank you to Ohio ACEP. This is me. I was actually the chair of the certifying exam work group, and I will get to kind of why we're having a new exam and what brought this all on. It is nothing short of a labor of love, I will tell you. This was not a bunch of people sitting in a smoky back room with cocktail napkins planning out how to torture residents. There was actually a really good reason that we are moving into this space, and hopefully I can elucidate that for you as we move along. So in today's conversation, I am going to give you a little bit of background about the American Board of Emergency Medicine. Many of you have already had a little bit of an exposure to us through the in-training exam, but I will help outline all of the steps that you have to go through to become board certified. I am going to talk about your role in all of this. And I specifically want to focus on the certifying exam. And then at the end, we will have a live Q&A session, and any questions that you may have, I would be happy to answer those. Sorry, let's go back. So really, what is ABEM? The American Board of Emergency Medicine, we certify physicians. That's the bottom line. We have the fourth largest cohort of specialty trained physicians in the United States. We are only outnumbered by internal medicine, pediatrics, and family medicine, and radiology and OBGYN are nipping at our heels, but we are the fourth largest specialty out there. In doing so, we encourage physicians who are trained in emergency medicine residencies to become certified. This is not a mandatory requirement. You do so on a voluntary basis. But in doing so, you accelerate your career, you accelerate an understanding of what your training means, and a sense of confidence in the public that you serve and the employers who are paying your daily wage. The ABEM Board of Directors is made up from volunteers across the country. We are 17 hardworking, clinically active, which is a key, physicians of varying skills and backgrounds and subspecialty training. And we also have public members who help us with expertise and family and patient engagement. So how does ABEM fit into your career? ABEM certification will be valuable to you in your career in that it's added compensation, gives you recognition as a specialist. As I mentioned, it gives the public and patients trust in you, that you have undergone not only a rigorous training, but a rigorous certification and evaluation process. It will increase practice opportunities for you, and not the least of which, it gives you a sense of professional pride. Once you become certified, it's really viewed as the gold standard for emergency physicians. It indicates that you are dedicated to delivering the highest quality care. You've demonstrated the skills and ongoing expertise needed to meet the highest professional credential in emergency medicine. And it also signals your commitment of staying up to date with the latest medical advances. This is not a lifetime certification, but you will be challenged to stay up to date on new medical innovations. And we also believe that certification really shows that you can lead the care in the emergency department. Like 80% of the public, we believe physicians should be leading emergency care. And especially as the emergency departments have a wide cast of characters that are currently working, including physician assistants, nurses, nurse practitioners. They all play important roles, but emergency physicians should be the ones leading care. So we really look forward to working with you and achieving your certification. We'll work with you to ensure that the pathway to ABEM certification is easy to understand and the process goes smoothly. And one of the things that I'll be referring you to frequently is ABEM's webpage, not so difficult, www.abem.org. So let's talk about that process and what does it mean. The purpose of initial certification is to objectively and independently confirm that physicians who complete an EM residency demonstrate core knowledge, skills, and abilities needed to practice emergency medicine at the highest standards. As you've heard, and probably why you're signing into this webinar, the certification process is changing. You will apply at the end of your terminal year of residency, the end of your third or your fourth year of residency. You will take the qualifying exam, and there are no changes to the qualifying exam. The qualifying exam is offered in the fall of after you graduate from residency. But now, rather than taking an oral exam, which will be retiring at the end of 2025, we only have 2 more oral exams to give. In 2026, the final step for certification will be the new certifying exam. And before we dive into that, I want to make sure you understand the initial steps and look at those carefully. Apply. You'll take the qualifying exam. Once you pass the qualifying exam, you will be offered a seat for the certifying exam. And once you pass the certifying exam, you will become ABEM certified. If there's one bit of very concrete information and advice that I can give you during this time, it's don't delay certification. Apply in that terminal year of your residency in April. Sometimes people feel like I haven't read Rosen's cover to cover yet. I want to wait a year to start my certification process. every year that you wait after graduating for residency, your chances go down in the success of passing the qualifying and then the certifying exam. So don't wait. Right out of residency, it's important that you go ahead and apply. Okay, so if you're graduating on or before October 31st of this coming year, applications are sent out to programs in April. You will apply. Once your application is accepted and your program director has signed off that you have completed an emergency medicine residency training program, or that you will complete that training program by November 1st of 2025, then you can register for the qualifying exam, and you are considered board eligible at that point. The registration for the qualifying exam itself, you're going to register between May 6th and October 9th. Again, don't delay. There's a late registration fee if you have to go after October 9th. The qualifying exam is given in a 1-week administration window, which is going to be between November 3rd and 12th. It's given at Pearson VUE testing centers, which I think there are like 300 Pearson VUE centers across the United States. And there's one in every major city in Ohio. It is a 305 multiple choice questions. It is criterion referenced, and we'll be talking about this a little bit, just what criterion referenced means. And you should get your scores back from the qualifying exam within 90 days. So here is the qualifying exam standard pass rates. It is criterion referenced. And what I'm talking about when I say criterion referenced is that if everybody does beautifully on the exam, everybody passes. If everybody does abysmal on the exam, everybody could potentially fail this exam. The criterion that all the tests that ABEM devises are referenced against is what a practicing emergency physician knows, what skills a practicing emergency physician has. So we set these based on expert panels of practicing emergency physicians. And that tells us that even though you've seen kind of a gradual decline of the rates of the qualifying exam passers over the last 5 years, that the exam's not getting harder. There's something else going on. So for first-time test takers, it's now 82%, and the pass rate for all comers is 80%. And this is definitely lower than 2023, but it does follow that multi-year trend. So let's move on now to the certifying exam. That's really what you're here to hear about today. Now that we've kind of set the steps for how to get there, we'll talk about the exam itself. It's a new exam, but the idea and the building of the exam are not new ideas for ABEM. The certifying exam is an outcome of a multi-year initiative. So why did we come to this decision that we needed a certifying exam? ABEM did a listening tour, a national listening tour, through surveys, focus groups, interviews, summits. This is a picture of the Becoming Certified Initiative Summit. All in all, ABEM heard over 4,300 opinions on what does ABEM test, what should ABEM be testing, what do employers want, what do practicing emergency physicians feel needs to be assessed, and also, equally as importantly, what confidence does the public put in an assessment, and what critical skills do the public really want to know that we are assessing for directly? So the BCI Summit, that the picture here, was an assessment in innovation. It said that we really should think about using simulation. One of the clear-cut messages is that we should be assessing communication and interpersonal skills, that we needed to focus on some of the future skills that emergency physicians would need, including being the captain of the ship, being the one under whom a lot of other providers are working. So as the emergency medicine entire practice has changed, really the certification has to change in order to meet new demands in emergency medicine. certification is more important than ever. And one of the things that we clearly heard from every one of the 4,300 voices that we surveyed was that we needed to maintain those high standards. But we also needed to assess more than medical knowledge. In the day and age when information is available at your fingertips, and it doesn't matter if you know the exact distribution of the L5 dermatome, because that information is clearly available to you, we had to better assess skills and competencies that were important to the specialty and that were relevant to the practice and that could be adapted to changes in medicine. And we needed to keep that assessment meaningful. We needed to keep it valid, and we needed to make it be reliable as well. This is the only thing in a very concrete sense, besides residency training, that differentiates emergency medicine trained and other trained physicians. But it also differentiates between physicians and non-physician providers. So the certifying exam format is that it's a half-day in-person session. The new in-person session we're going to be testing in a testing center. It's not a simulation center, it's a testing center in Raleigh, North Carolina. And there are going to be two broad case types for this, clinical care cases and communication and procedure cases. So I'm going to tell you about kind of the big groups and then separate out each of the cases embedded within those. So the clinical care cases are going to be facilitated by an examiner, in most cases, two examiners. They're designed for you to be able to demonstrate how you prioritize patient care, assess to the adaptability of unexpected clinical changes, and interact with various sources of information. The communication and procedure cases assess communication, professionalism, and the essential technical skills necessary to care for patients. So what do I mean when I say this? The clinical care cases are going to be 15 minutes long, and they're going to be 4 cases per session, 2 examiners per room. And there are 2 types of clinical care cases. The first is a clinical decision-making case. Now, I know that many of you were thinking, well, I've done board prep with my residency training program. Is all of that just a waste of my time? The clinical decision-making case will look very, very much like the structured interview case. And if you haven't done a mock structured interview case, well, the first thing I want to do is encourage you to go to the ABEM website and take a look at what one looks like. But still, if you haven't done a structured interview case, imagine that you're presenting an undifferentiated patient to your faculty, to your attending when you're working in the emergency department. What would you do? You would tell them the pertinent parts of the history and the physical exam that you've gathered. You would give them a differential diagnosis. You'd discuss a diagnostic workup with them. You'd talk about initial management steps for the patient. You'd circle back and interpret those diagnostic studies and come up with a more firm diagnosis and a disposition and ultimate patient management steps moving forward. That is exactly what the structured interview does. It is a conversation that you're having with 2 examiners across the table from you about an undifferentiated patient that you get a chief complaint and initial set of vital signs on. Should look very familiar to you. And like I said, the structured interview is very much of this spirit or of this same fashion. Now, the one thing that's different, and you probably have seen this as well in presenting cases to your faculty, are they may ask, why are you doing that? Why are you getting a CT as opposed to an ultrasound? Or, well, what did that EKG show you? Or can you interpret that chest X-ray for me? Those kind of peppered questions are definitely, the rationale questions are peppered into the clinical decision-making cases. The other type of tabletop case or clinical care case that you're going to be seeing, and you'll get 2 of these cases, is a prioritization case. Again, this should feel very comfortable for you. I like in the new certifying exam that you can wear scrubs, and truly you can wear scrubs to this assessment, and tennis shoes, and walk right into it and feel like you're kind of in an emergency department setting that you'd see. So you're scheduled to work a Friday evening. You're coming on at 7 p.m. You have a tracking board sitting in front of you with 8 new patients on it. How are you going to decide who to go see first? What critical interventions might that patient need? How are you going to decide in your own internal triage who you need to go see second? Who else can you send to gather information, critical information that, does that ankle injury have pulses? Can somebody else check that for you? That is going to be the tracking board type of the prioritization case. The second type of a prioritization case may be a triage of multiple patients arriving without warning, a mass casualty incident. You may have a few patients in the emergency department and then 3 or 4 of them come in. And what do you do with them? And how do you delegate care to others so that they can manage the rest of the patients? Or it may even be a patient with multiple injuries, and you have to prioritize which of those injuries you're going to address and stabilize first. That is the clinical care part of the cases. So if you are doing a half-day exam and you happen to be in the morning, you'll come to the center, you'll be oriented, you'll do 4 15-minute cases with 5-minute breaks between each one. And then you're going to have a 20-minute break, and you're going to move over to the second part of your exam, which will be the communication and procedural cases. These cases are kind of all new and probably the ones that candidates are having the biggest angst about. I'm going to say it here, but I'll say it again, and I'll say it again. All of these cases have case samples on the ABEM website. We are tracking numbers of people viewing these, and I think that they're not penetrating, they're not getting into the community. So I would really encourage you, go to the ABEM website, look at a reassessment or troubleshooting case, look at a difficult conversation case, and you will see that, again, this looks very similar to what you do day in and day out in the emergency department. So these are 10-minute cases. They're going to be 6 cases per exam session. You're going to have a procedure and an ultrasound case, and both of those cases are going to have an examiner in the room with you. The other 4 cases that you have besides the procedure and the ultrasound case will have standardized patient actors. There's not going to be an examiner in the room with you. Your performance will be videotaped and recorded and will be scored asynchronously to the exam. And the content areas where you are going to be interacting with a standardized patient actor are reassessment and troubleshooting, difficult conversations, which I encourage people to look at difficult conversations as more like breaking bad news. Managing conflict, and then you're going to have 2 patient-centered communications. And these are reassessment and troubleshooting is just that. Somebody returns after being seen in the emergency department already, and there's a new diagnosis that you have to make. And can you pivot and not anchor on the old diagnosis? You're treating a patient and the interventions that you choose don't seem to be working appropriately. How do you troubleshoot that situation and pivot down a different pathway? The breaking bad news, these are things, unfortunately, that we're faced with all the time in emergency medicine. How do you give an unwanted diagnosis? How do you tell somebody out about a tragic or unexpected loss? Managing conflict is a little bit different than that. Now, we have conflict with patients for sure, right? We want our patients to do something that we think is in their best interest, and they may not want to do that. That is one type of conflict that we manage, but other types of conflict are, your consultants being a particular rascal on this day and giving you a little bit of trouble. How do you manage that conflict? How do you manage conflict if your nurse says, well, I'm not doing that? How do you manage conflict if you want to get somebody admitted to the hospital and the hospitalist doesn't want that? Those are the kind of conversations that you're going to have in the first 3 of those categories. The last category, patient-centered communication, is just what it says. There's going to be a patient who comes in with a chief complaint. How do you get a history? How do you do a physical exam? You're not going to actually lay hands on to do the physical exam. Physical exam findings will be handed to you. But how do you discuss with the patient what the workup should be, what their diagnosis is? How do you assure that patient is going to have success in their treatment plan that you are prescribing? And then ultrasound and procedures, I'll talk about a little bit in detail because they're just a tad bit different. I saw some questions in that this group had submitted prior to this talk. And there was a lot of angst about procedures. Are you going to come to the assessment and ABEM's going to ask you to reattach a hand that's been severed, or that ABEM's going to ask you to do a resuscitative hysterotomy? We are not. We are testing main procedures in emergency medicine. Will there be a list that you'll be able to see ahead of time when you walk into this exam? Yes, we will have a list, and we probably will have a list for you within the next couple of months. But think major resuscitative procedures, think common diagnostic procedures that you do in the emergency department. Think common therapeutic procedures that you do. Ultrasound is the other one that we get a lot of questions on, because there are as many different ultrasound machines as there are people who do ultrasound, it seems. So what you will be asked when you walk in with the examiner in the ultrasound station, you'll be given a clinical vignette. You'll be asked to decide what images might help you through that clinical vignette. You'll be asked to select a probe. You'll be given a probe. There'll be a standardized patient there, and then you don't have to touch the machine after that. So you don't need to know any of the knobology. You don't have to know how to turn the machine on. You don't have to know how to save images. All you need to do is be able to tell the examiner, can you increase the depth? Can you decrease the gain? Can you turn on M mode? And the examiner in the room with you will do all of that for you. Okay, we've spent long enough on this slide. I feel like I've gotten a few more gray hairs since I started talking about it. So let's move on. As I mentioned, the clinical cases are going to be 2 examiners per room, and both of the examiners are going to be scoring independently. I also noted that there were a lot of questions about scoring and how we're doing scoring. This is one way that we are assuring inter-rater reliability and trying to decrease implicit bias and the role that bias may play in scoring. And the 2 examiners in a room, if those 2 examiners have scores that are unacceptably different, then we would have a 3rd and a 4th examiner review the tapes from that case and make sure that there is concurrence with them. We're also doing that on a random case basis. We're pulling extra examiners in to review cases. And we've talked about the 2 different types of the clinical cases: clinical decision-making and prioritization. And then the ASCII cases. There is going to be an examiner in the procedure and in the ultrasound case. The other exams are going to be scored asynchronously for the ASCII cases. So for troubleshooting, difficult conversations, managing conflict, and patient-centered communications, you will just be interacting with the patient. And sometimes there will be a confederate in the room that is a nurse or maybe acting as a nurse. This, as I mentioned, was a sample case schedule. You may start with clinical decision-making, go to a prioritization case, back to clinical decision-making, and back to prioritization. And this is the other important thing on the ASCII cases. Everybody gets a troubleshooting case. Everybody gets 2 patient-centered communication cases. Everybody gets a procedural case and an ultrasound case. But you will get either a difficult conversation case or a managing conflict case, one or the other. So who's developing this? Contrary to common folklore out there, these exams are not written by a squad of drunken monkeys. They are actually developed by ABEM certified physicians and patients. And all of the ABEM certified physicians that are part of case development are clinically active. We also have public members who are helping us develop cases, and we're developing them right there in Raleigh. So we know that the infrastructure that you'll be in, the actual building, that we've worked out all the kinks and the flow, and that's who's involved with the case development. Oh, I'm going to skip the video, sorry. But as I mentioned, we also have public members. We have 4 public members who are involved with this, and they're really an important part of our process. Ultimately, we're beholden to the public, and we're beholden to patients to deliver great care in their name. So it's important that we get the public's perspective as we move through this process. ABEM actually takes bias and fairness very seriously. We are part of the National Commission for Certifying Agencies, and we're accredited by that. It really demonstrates that we have the highest standards for fairness, reliability, and validity, and we're the only American Board of Medical Specialties that is NCCA accredited. We have experienced professional patient actors, which also increases the reliability of the exam itself. We have a scoring and an equating process that adjusts for variance in scoring stringency. And all the ABEM staff, directors, and exam writers undergo bias and training workshops as well. The exam cases themselves undergo bias review. And all examiners are evaluated during every exam for case administration and scoring accuracy. And then, as I mentioned, there is also a random selection of cases that get multiple reviews to screen for bias and fairness. So why do we even have an in-person oral exam? We've had one since 1980. That's not a good reason to have one, just because we've had one for so long, but it is a very bedside specialty that we have. The virtual format was implemented of the oral exam during COVID. Most ABMS boards that have a lot of patient interaction have an oral exam, and most of those boards have returned to an in-person exam. The virtual exam was valid and reliable, but clearly what we heard from the Becoming Certified initiative was that it did not assess for future emergency physicians because it didn't really look at the entire breadth of competencies that the public and that employers and other physicians thought were important. So where are we having this? We're having it at the ABEM Center, as I mentioned, in Raleigh, North Carolina. It's not a huge lift for people from Ohio to go to Raleigh compared to Chicago, where the old oral examination was. It is not a simulation center. It is a professional assessment center. We have about 3,500 candidates or recent residency graduates that need to be assessed every year, and this center can handle that volume of candidates. In doing so, we're going to need to have more administrations throughout the year, and I'll go through the administration schedule with you. Because there are going to be more administrations throughout the year, you should have greater scheduling flexibility for this. I think ultimately you're going to find that this is a pretty smooth and flawless candidate experience. All you need to do is get yourself to the hotel in Raleigh. You're going to register at the hotel. Proctors are going to guide you through all the logistics. You just arrive at the hotel on the assigned day and time. The administrative infrastructure of the center itself has been developed and proven. The American Board of Anesthesia gives its certifying exam there. And they've actually been able to show that it's a fair, equitable, and standardized experience for all candidates. The patients are experienced, professional medical actors. And there's also, we have locally, we have partnership with, in the event that emergency care is needed, through Wake Emergency Physicians. The standardized patient actors, I will say, have been an absolute blessing in developing this. They will not be scoring your cases. You will only be ever scored by a physician. But these standardized patient trainers do help with case development, and they're really trained for high stakes certification examinations. They also represent a very diverse patient population, which we see in emergency departments. We will have accommodations for active military deployment, if you have religious observances, if you have family leave concerns, or if you have fellowships. There are on-site Americans with Disabilities accommodations, including wellness rooms, candidate accommodations for nursing mothers, altered schedules for nursing mothers, allowance for medical aids as needed in the testing rooms, and we actually have quiet rooms in the center as well. So these are the exam dates. All of these are in 2026. If you're graduating this year, you may want to take a quick screenshot of this. We're looking at flexible scheduling options. You as a candidate will have input and the ability to request exam administrations and share conflicts with us for those that do not work. Exam candidates will be assigned to a half-day session during one of the multiple exam administration windows throughout the year. And you may not be able to say specifically if you're going to be in a morning or an afternoon session or a Tuesday versus a Wednesday. So we may not be able to accommodate all requests, but this is one of the things that we are trying to do to make sure that there is more flexibility as opposed to the 3 current oral examinations that we offer yearly. This is what I mentioned about the sample case videos. So important that you get a look at those, see what it means when we're talking about breaking bad news or managing conflict. The sample case videos are not there to demonstrate a superstar candidate, nor are they there to show you somebody that wasn't going to pass the exam. These are kind of run-of-the-mill candidates in what we expect that an emergency medicine resident should be able to perform within that sample case. There are scoring guidelines on the ABEM website as well. There are case references and there are case summaries. So take a look at this. The case summaries are really important because right underneath them it says a competent or a successful candidate will be able to A, B, C, D, E. Are you going to be scored on A, B, C, D, E? Yes, you are. That is as transparent as we can be with what a scoring rubric is going to look like for these cases. And again, here are the sample cases, and each of these you can scroll through and get a real live idea of what a patient-centered communication looks like or what a procedure looks like, something like that. There's a case video available for each of the 8 case types, including a PDF of the case material. Each case type is specifically designed to assess different competencies important to the specialty, but not explicitly anchored to case content. So it can be anywhere over the emergency medicine model. And the videos have accompanying case materials with them as well. So how to prepare? Without a doubt, you are going to study differently for the certifying exam in the future. But the goal of ABEM is not to create a tougher examination that more candidates will fail. That is not our goal. Instead, this is an exam that is indicative of what an emergency physician should be capable of doing before embarking on an independent career. And it really does meet the standard for independent practice and the standard of the specialty. Seek feedback by your faculty. If you have not had a faculty member in your department hear you break bad news to a patient, this is your chance. If you don't have that opportunity that occurs organically in the clinical setting, ask a faculty member to mock that for you, to be somebody that you can break bad news to. The new skills will assess the type of skills that you use every day. So really just take full advantage of your residency training. Discuss the why when you're presenting cases to your faculty. Make sure that they see you doing ultrasound exams. Make sure that they can listen to you manage conflict with a consultant or with a patient who wants to leave and you don't want them to leave. That is going to be the standard to which you will be measured the performance of an active emergency physician. So really, you've been preparing for this new exam since starting residency. The cases are really similar to conversations when you're presenting to your attendings, and please use the resources that are available. All of these cases are going to be mock tested and evaluated multiple times prior to administration. We need to make sure that they're fair, reliable, and valid. But this really should feel like a more realistic exam to you. It's less artificial, there's less contextualization, there's less test-taking technique. You don't have to walk into a room and say, what do I hear, see, and smell? Well, what you hear, see, and smell is whatever that standardized patient actor smells like in front of you. And what you hear is what they're saying to you. And what you see is what you see. So I think that there should be a lot less of the gamesmanship associated with this and a lot more really focused just on what you do every day in the emergency department. Here are some QR codes. Again, all of these are available through the website, which is www.abem.org. But there's separate pages for about the certifying exam, the exam content, the exam scoring, and then additional resources as well, including all of the really the amassed citations that we used that demonstrate what these best practices are. So to recap kind of what's next for you. You're going to graduate. If you're graduating in 2025 or after, you're going to apply. You're going to take the qualifying exam and pass it, and then you're going to be offered a seat on the new certifying exam. When you're offered a seat, please let us know your availability, but take the test. Take the test as soon after you pass the qualifying exam as you can. It's nice to get that kind of unweighted off your shoulders. It's nice to be able to move from being board eligible to board certified, but it's also going to be your best chance to pass this test if you take it straight out of residency. We are developing orientation videos that will help walk you through the candidate logistics and a walk through the center, and we're going to be giving you periodic updates as well. So keep in mind, we have a shared interest with you. You want to pass this exam, and we want you to pass this exam. We want you to go out and be fruitful and certified and competent emergency physicians. But we want your ABEM certification to have value, and we want it to be valued by hospital systems, by insurers, by the public, by patients, etc. And every step along this way, we're here to support you. So if you have any questions about ABEM, if you have any questions about this presentation, there's going to be an email at the end of the presentation. You can email us any question you have. Please don't make reference to the drunken monkeys. That's my own specific twist that I put in this lecture, and not ABEM certified language. We support you throughout your career, though. Once you become certified, we're working to help promote to the public that your certification means something and the value do you bring to the emergency department in your community. You can download letters of support and forego merit badge requirements. The continuing certification requirements you're going to be doing supersede the need for such training and courses. We want to promote your certification. You're going to be provided with materials to share your ABEM certification status, including board certified logo press release templates to give to your institutions and more. And we want you to stay current and up to date. And we've done that through a new continuing certification process that is so much easier for physicians. It's not a high stakes exam anymore. There are yearly modules that you take that really serve to educate and not just test and not just evaluate. And at some point in your career, you may say, hey, this is okay. I want to get involved in the work that ABEM is doing. There are lots of volunteer opportunities, and above all, we're really listening to your feedback. So please do give us feedback on these. Volunteer roles include case developers, on-site clinical case examiners, on-site procedural case examiners, backup examiners, and remote examiners. And here's where you find resources, www.abem.org. So I am happy to, ABEM, you can email us as well, abem@abem.org, or you can call the office, pick up a phone and call. I know that that's a kind of a forbidden thing to do generationally, but nonetheless, you can email us if you'd like, and I would be happy to answer any questions that you may have as soon as I stop sharing my screen.
Thank you. That was an incredible presentation, very informative. I know a lot of people wanted to be here, but they couldn't because of work conflicts. So we did get some questions in advance. I could start off by asking one, and if anyone that's on wants to raise their hand, we could have you ask the next one. If not, we've got a list of questions that have been submitted. Mm-hmm. I guess the first one was, you had mentioned about the anesthesiology is using that same testing center. And so was their original exam very similar to what we did and that they transitioned into this? And what is their experience, the negatives and positives, from their candidates?
Yeah, it's a great question. So, so they had an oral exam, then they also moved to a virtual oral exam. And then when they decided to build this center, it was 2018 or so when they instituted the center and started the exam there. They moved to virtual and then they came back in person after COVID. And that was the inciting reason for ABEM moving to a virtual exam as well. The American Board of Anesthesiology uses standardized patients. The differences between the ABA and us is that no other board has ventured into testing procedural competency. Emergency medicine is the first board that will do that. And we just think that it's critically important to at least test a sampling of procedural competency for graduates. So that is new. So I can't give you any experience that any other board has had with teaching or with testing procedural competency. The ABA, the pluses and the minuses, they have found that they have been able to give a very valid, reliable, and fair examination there. They have not run into any difficulties with reproductive rights in the state of North Carolina, which is a question that we sometimes get. It's a rather conservative state. They have run into some situations with the complaints about candidates having to come from the West Coast all the way over to Raleigh, North Carolina. We understand that that is a limitation of the center. We would have loved to have this center in Chicago, or as a matter of fact, we looked at one center in Omaha, Nebraska, which was a beautiful simulation center, but in no way was it capable of delivering 3,500 standardized examinations in a year. And a lot of institutions are building high-tech bells and whistles, technically advanced centers that are designed for very small group use on a continuous basis, as opposed to multiple times throughout the year and being able to assess 3,500 people. So that is probably the biggest ding that the Board of Anesthesia has taken, and that we anticipate taking as well on emergency medicine.
Just to go about, you had mentioned about the procedural part of things. On the website, it mentions about that high fidelity simulators won't be used, so no program. You know, if you train at a place that doesn't utilize those, you're not at a disadvantage. What are the simulators? What it would be an example of, let's say, a central line? What type of lower fidelity simulator, or how would that play out?
Yeah, and when we say really a high fidelity simulator, we mean like the $1 million Medimans that are out there that can do everything. And you know, you can hear breath sounds on them, and you can feel pulses on them, and everything like that. Imagine a smaller simulation lab where you had a task trainer. So there is a central line task trainer. There is a lumbar puncture task trainer. There are airway task trainers. Those are the type of simulation equipment that you're going to be expected to use. The other question that we get, and I'm really glad that you asked that question, Bob, because the other question that we get sometimes from people is, well, you know, I've done 100 intubations and I've never missed one, and now I come to Raleigh and I'm trying to do one on the, you know, plastic man over here, and I don't get it. Does that mean I fail the procedure? And no, it does not mean that you fail the procedure. There are a number of things that you're being evaluated on when you do the procedure, and clearly success of attaining the outcome of the procedure is only one of those things. So you can fail the procedure and still pass the module. The counter to that is you can ace the procedure and still fail the module because there are a number of other assessment points that go along with it.
I think to expand on that, just to kind of, is you had mentioned about the thing we're classically taught. What do you see, smell, and hear? I mean, people dream that, you know, kind of when they walk into the room, what do you see, smell, and hear? Since this is going to be more realistic, I guess the same question that, you know, a couple people had asked was, if it's going to be that more realistic, that I'm in the moment here, can I do everything right medically, the right medications? Can I come up with the correct diagnosis? And could I still not pass that case?
Well, it depends on the case. For reassessment and troubleshooting, if you're doing the reassessment and if you're troubleshooting correctly and you get all of the medically anchored assessment points, you're going to pass that case. But there are clearly cases where communication is the skill that we're looking to evaluate. So if you come to the right diagnosis and disregard the patient or don't communicate that, or those are assessment points that we're looking at. And again, I'm using the term very loosely here, like passing and failing cases. That's really not the way the exam is scored. It's scored holistically. So you don't get a single grade for each case, and then all of those are added up and averaged out or anything. But I think that the message that I want everyone to hear is that communication is important. And the one thing that we heard from the public was the only reason that they would want to be taken care of by a non-physician in the emergency department is there is a belief that they are better communicators than physicians. I don't believe that's true. I don't believe that the mid-level providers that I work with are better communicators, but we have to fight against that in emergency medicine. We have to fight against that public perception, and we have to message communication is important.
Okay. So that helps on that's kind of I know, Mary, did you have any other that you said you had gathered a couple other questions? Just so I'm not hogging the whole, and then I can.
No, you're fine. I think I sent you the list, but one of the questions that someone, if I recalled, you answered how often they'd be. You kind of also answered how they'd be graded. Would there be, if let's say anyone doesn't pass a particular station or whatnot, would there be opportunity for feedback for that candidate?
That's a great question. This is a holistic evaluation.
Mm-hmm.
Let me tell you the pluses and minuses of that. If we have candidates who don't do well in a certain sphere or a certain type of case, and we give them feedback that this was the albatross around their neck. Frequently, they try and improve that part of the case, but they don't necessarily do any better because their strengths would naturally carry them through. So the message, although it's very frustrating to hear, is the only way that you get better at passing a test is to do everything better. And the same is true with the in-training exam. Like people want to say, well, there were 2 questions on dermatology and I missed both of them, so I better study dermatology because then I'll do better on the test. There were 2 questions on dermatology. So it's studying everything. It's working to improve your skill set in its totality as an emergency physician that is really going to allow you to perform better on the test. So it's a frustrating answer, but the answer is we are probably not going to be giving specific feedback on specific cases or areas of improvement. It is not a formative evaluation. It is what's called a summative evaluation. But again, that's why I'm saying bring every drop of knowledge that you can out of your supervising physicians now.
Thank you for that. And then the other question I got was, what about for those people that have test taking anxiety, or they get tongue-tied, or take them a minute to sort of, kind of get comfortable? How do you have any advice for those people who just sort of need to feel more comfortable, and it may not be a knowledge thing, it just is an anxiety thing? Any advice for that?
Well, let me separate this first out clearly to say if you have a documented psychometric need, neuropsychiatric need to have testing accommodations, ABEM will take that into consideration. So you have to fill out the same paperwork that you've had to fill out in medical school or in residency when you took the in-training exam. But that's kind of one end of the spectrum that we're talking about here. If you have a disability that requires that you have more time during testing, we will take that into consideration. If you're worried, if you have natural anxiety, which believe me, I can't tell you how much I sweated during my oral boards. Then some of the advantage is that you're going to have that 5-minute break between each case that you can kind of recenter yourself and keep in mind to just immerse yourself in the environment. This should not feel as much like a testing environment as the old oral examination or the old virtual oral examination. You don't have to remind yourself to say IVO2 monitor and 2 large bore IVs and, you know, the neonate that just rolled in the door that makes no sense or something like that. This should be something that you have, the anxiety should have been mitigated through your training, the many years of training that you've done. But just keep in mind, we're not out to get you. This is an opportunity for all the candidates to show us their skills, their knowledge, their abilities to practice emergency medicine.
Thank you very much. And I also want to thank you for, the segue of, if you do have a need, if you have, metrics, if you, that it is something that you guys will take into account, because I think a lot of times it is something that it's not discussed enough in residency. And so thank you very much for pointing that out. I really appreciate that.
Thank you.
I think the one thing to just go to the anxiety part, because I agree with you. I mean, my oral board was 35 years ago, and I can actually still remember each of those rooms that I was in. And there always is that disconnect that ABEM is not out to get you. We want you to succeed. But then there's always that fear that, I don't know all the rules. I don't know all of this. And I mean, I think a lot of programs, the residents feel more comfortable because they're constantly going through that. What do I see, smell, and hear? Do you feel that right now, because this was the big question I got from people, do you feel that those resources right now that are on there are enough for program directors to look at and say, okay, I can put together 10 cases right now, and going forward, we are now going to do everything in that format so you are comfortable?
I think that there are enough resources on there to do that. The one, we have heard the feedback that people would like more transparency in the scoring rubrics. That is kind of like saying, can you give us the test key? So we are willing to listen to that feedback, and what we're going to be doing is producing videos that specifically link to the case administrations that are on the website, with people discussing, here would be an assessment point. This would be another assessment point. This is where the examiner may be looking at either X, Y, or Z to determine if the candidate did this. So that, I think that takes it to another level of comfort for program directors. I would encourage people, I think that the most anxious folks that I've talked to are those folks who haven't really engaged with the material that's out there. Look at the citations, look at the case descriptions where it says a successful candidate should be able to A, B, C, D, E. And those are pulled almost directly from the citations, and the citations will all of those curated citations will specifically mention this is the value of looking at A, and this is what a successful candidate would do to demonstrate that first assessment point. So I think that there are really great programs out there that are well immersed in this and really doing a great job of some preparation.
Mm-hmm. I know we're just a tiny bit over. Can I just ask one last question? Because there was one about, you had just led into the grading rubric, that on the exam where there's 2 examiners in there.
Mm-hmm.
I know the whole goal that ACEP or ABEM really trains the examiners to be within a certain standard deviation.
Mm-hmm.
Will the candidate get what the final grade, or if they found out that one examiner gave them a 7 and one was consistently giving 5s to 4s, will they be able to see that difference? And are these videoed, and could there be an appeal on that end?
So the basis for an appeal is not a scoring appeal. The basis for appeal is if a candidate thinks that something went awry in the administration of the exam. Their standardized patient had a real stroke in the middle of the exam. That would be a great reason to appeal. But the inter-rater reliability and how that is looked at, ABEM would not feel comfortable putting a score like that forward without getting further input on that. So if there was a kappa value and inter-rater reliability that was far askew, we would have a third and a fourth person look at the taped at the taped encounter for that, to make sure that there wasn't that reliability. I will tell you that these cases are trained and they're trained and they're trained. When you are an examiner, you are given 2 cases all week long, and those are the only 2 cases that you give. And we anticipate almost every response of a candidate that could occur. So part of it is process beforehand and preparation for that. Part of it is after the fact and looking at scores and making sure that we have the reliability and having additional scores in case that happens.
Okay. Well, I think we all do, your time. I mean, this was incredibly, even as a oral board examiner, I learned a ton from this today. So this is
Fantastic.
very helpful. And Holly or Steph, do you have anything on the chapters end to?
No, thank you very much. I took a lot of notes. I think you had some great highlights, and I appreciate you taking time to do this.
Well, it's truly my pleasure. We want people to be out there, out there to feel comfortable and prepared. And what we're testing is just fair emergency medicine stuff. So please, if you have any questions, abem@abem.org will get you to the email.
And we'll share this link that way this could not just be for Ohio,
Perfect.
Candidates that, Mary, do you have any final thoughts? And again, thank you for also doing this.
No, absolutely. It's my pleasure. Dr. Gorgas, I cannot thank you enough for being here, for answering all of our questions, and just truly thank you so much for being, that guide to make sure that we meet our patient standards and that we have a standard set for our field. So I cannot thank you enough, and I look forward to continuing to working with you.
Thank you. Go Ohio.
Thank
Go
you.
Bucks.
All right. Thanks.
Bye-bye.
Bye.